Our next topic is gestational hypertension. What is gestational hypertension? New hypertension after 20 weeks of gestation without significant proteinuria. What is a significant proteinuria during pregnancy? Significant proteinuria is proteinuria of more than 0.3 gram per 24 hour. So new hypertension after 20 weeks of gestation without significant proteinuria is gestational hypertension, and new hypertension after 20 weeks of gestation with significant proteinuria is preeclampsia. And if a preeclamptic patient develops,
Sorry, did you say with or without proteinuria?
Without proteinuria, it will be gestational hypertension, and with proteinuria, it will be preeclampsia. Proteinuria should be significant to say that it's preeclampsia. And what is a significant proteinuria? Significant proteinuria is a proteinuria of more than 0.3 gram per 24 hours. So new hypertension after 20 weeks of gestation without proteinuria is gestational hypertension. With proteinuria is preeclampsia. And if the patient develops seizure, then it is eclampsia. The treatment of gestational hypertension, the first line drug to treat gestational hypertension is labetalol. Labetalol is a beta blocker, and oral labetalol are given in patient with gestational hypertension. It is safe to use in pregnancy, but as it is a beta blocker, so it can cause bronchoconstriction in asthmatic patients. So that's why if an asthmatic female is diagnosed with gestational hypertension, then the drug that we can give is a calcium channel blocker such as nifedipine. So first line drug is labetalol. If the patient is asthmatic, then we'll give nifedipine. And if nifedipine is contraindicated also, then we'll give methyl dopa. So remember these drugs, these three drugs: labetalol, first line. If labetalol is contraindicated, then nifedipine. If nifedipine is contraindicated as well, then we'll give methyl dopa. These three drugs are safe in pregnancy as well as they are safe in breastfeeding as well, because they are not secreted in breast milk. What is the definition of significant proteinuria? Significant proteinuria is more than 0.3 gram of proteins in a 24-hour urine sample, or a protein creatinine ratio of more than 30 milligram per millimole, or an albumin creatinine ratio of 8 milligram per millimole. So remember these three criteria: either more than 0.3 gram protein in 24-hour urine sample, but because it is difficult to collect a 24-hour urine sample, so we give a spot protein creatinine ratio or an albumin creatinine ratio on a urine sample. And if PCR is more than 30 milligram and ACR is more than 8 milligram, then we'll say that it's a significant proteinuria. Stage 1 gestational hypertension does not require any treatment, only observation is needed, and we will only treat the gestational hypertension if the blood pressure is above 149 over 99. And the drug of first line drug is oral labetalol. If contraindicated, then nifedipine. If it's also contraindicated, then methyl dopa. Now hypertension, new hypertension after 20 weeks and proteinuria, significant proteinuria, then it will be known as preeclampsia. And if the patient start to have tonic-clonic fits as well, then it will be known as eclampsia. To control hypertension during preeclampsia, we can use the same drugs such as labetalol or nifedipine or methyldopamine. So they can be used in eclampsia and preeclampsia to control blood pressure. Along with these medication, close monitoring of the baby, of the mother is required, because preeclampsia can develop into eclampsia and it can complicate the pregnancy. So that's why we need to closely monitor the patient, as well as give magnesium sulfate to prevent seizures. So for hypertension, we give labetalol, nifedipine, or methyldopa, and to prevent seizure, we give magnesium sulfate. The doses of magnesium sulfate will be discussed shortly. First, we'll discuss what are the fetal complication of preeclampsia. Fetal complication of preeclampsia is preterm delivery, oligohydramnios, and suboptimal fetal growth. And what are the maternal complication of preeclampsia? The maternal complication of preeclampsia is it can cause liver failure, it can cause kidney failure, it can cause bleeding and clotting disorder, and it can cause HELLP syndrome. So this one is important. Maternal complication, that is HELLP syndrome. So preeclampsia is a risk factor for HELLP syndrome. Don't forget this complication of preeclampsia. Other than that, liver and kidney failure can also occur. So in preeclampsia, which drug we need to give to prevent seizure? That is magnesium sulfate. So if the patient develops seizure, control the seizure, magnesium sulfate can also be given. It can also be given to prevent the seizure. Normally, a 1 gram IV bolus of the magnesium sulfate is given if a person develops a seizure, and if another fit is developed, another IV bolus of magnesium sulfate is given. What are the treatment regimen that is usually used? Normally, a loading dose of magnesium sulfate, that is 4 gram in 100 ml of normal saline, is given by infusion pump for 5 to 10 minutes. So a loading dose of 4 gram is given in 5 to 10 minutes. Then followed by a maintenance dose of 1 gram per hour for 24 hours after the last seizure. 4 gram in 100 ml normal saline in 5 to 10 minutes is the loading dose. Then the maintenance dose is 1 gram per hour for 24 hours after the last seizure. But if during this regimen recurrent seizures occur, we have two options: either to give a further 2 gram magnesium sulfate bolus, or increase the rate of infusion to from 1 to 1.5 or 2 gram per hour. So the patient can develop magnesium sulfate overdose as well. And how you can diagnose the overdose of magnesium sulfate? If a patient with eclampsia or preeclampsia who is on magnesium sulfate infusion develops these silent symptoms, then you can say that it's a overdose of magnesium sulfate or magnesium sulfate toxicity. What are the sign and symptom of magnesium sulfate toxicity? Magnesium sulfate, remember that the mechanism of action of magnesium sulfate is that it prevents the entry of calcium ions in the nerve terminals. And the entry of calcium ions is very important for neurotransmitter release. So high doses of magnesium sulfate will lead to a loss of deep tendon reflexes, nausea, vomiting, and confusion. So if patient with a history of eclampsia or preeclampsia on magnesium sulfate infusion develops loss of deep tendon reflexes or confusion, nausea and vomiting, then you will say it's magnesium sulfate overdose. And the treatment of magnesium sulfate overdose is IV calcium gluconate. 1 gram of IV calcium gluconate in 5 to 10 minutes is given as an antidote of magnesium sulfate overdose. Other things that you can do is to stop the magnesium sulfate and request magnesium sulfate level urgently. And if the patient develops a seizure or if there is still ongoing seizure, because we cannot continue magnesium sulfate because its toxicity has developed. So in that case, we'll give a diazepam injection for the control of seizure. After management of the seizure and the patient is stable, delivery is done through a C-section. So this was all about gestational hypertension, preeclampsia, eclampsia, its management and management of magnesium sulfate overdose. Is it clear, everyone, up to this point? Is there any question? So there are two scenarios which can be asked in the Plab 1 exam regarding proteinuria in pregnancy. So a woman with 2 plus proteinuria, they should be urgently referred to a secondary care clinic, even if the blood pressure is normal. And a woman with 1 plus proteinuria and normotensive, she should be reviewed and reassessed in 1 week in a GP clinic. Remember these two scenarios because a question related to these scenarios was asked in the previous exams. A woman with a normotensive woman with 2 plus proteinuria in pregnancy, you will refer her urgently to a secondary care clinic same day or within 24 hours. And so basically for 2 plus proteinuria, it is an emergency referral. And for 1 plus proteinuria, you will review and reassess the patient in 1 week in a GP clinic. So an example is given if a pregnant lady at more than 20 gestation present with proteinuria plus 3 and hypertension and this, you refer her to a maternal unit or a secondary care clinic. Similarly, another example with 1 plus proteinuria. So remember that women who are at moderate to high risk of developing preeclampsia are given aspirin 75 or 150 mg daily. They are started from the week number 12 of pregnancy until delivery. So women who are at a moderate or high risk of developing preeclampsia, they should receive prophylactic aspirin at a dose of 75 or 150 milligram daily. Example of the women who are at increased risk of developing preeclampsia include previous history of hypertension or preeclampsia during a past pregnancy, family history of preeclampsia, pregnancy at an age of above 40 years, BMI of more than 35 kg per meter square, chronic hypertension, chronic kidney disease, antiphospholipid syndrome, pregnancy interval of more than 10 years, diabetes mellitus, twins or triplet pregnancy. All of them should take aspirin 75 mg prophylactically. So an important complication of pregnancy is HELLP syndrome. Preeclampsia is HELLP syndrome. We discussed HELLP syndrome in the GIT chapter, but still I will discuss it here again because it is a complication of preeclampsia. So a woman with a history of preeclampsia, if she present to you with hemolysis, elevated liver enzyme, and low platelets, then we'll say it's HELLP syndrome. Due to inflammation of the liver, there will be epigastric or right upper quadrant pain and tenderness. Along with that, there will be nausea and vomiting and dark or tea colored urine. Because of hemolysis, the color of the urine will be dark or tea colored. Plus minus other features of preeclampsia can also be present. The treatment for HELLP syndrome is delivery of the baby and magnesium sulfate if the patient develops seizure. Risk factors are again multiple pregnancy, gestational hypertension, antiphospholipid antibody syndrome, etc. The management is delivery of the fetus. It is definitive if gestation is more than 34 weeks, because until then the patient or the fetus lung has matured, and because there is hemolysis which can lead to anemia, so transfusion of blood products, plasma exchange in severe cases, and magnesium sulfate to prevent preeclampsia. Now, another condition that is present during the pregnancy is acute fatty liver of pregnancy. In acute fatty liver of pregnancy, HELP is present or HELP without H. So there is no hemolysis. Acute fatty liver of pregnancy is basically due to mitochondrial dysfunction in the oxidation of fatty acids. The cause of this mitochondrial dysfunction is not known, but mitochondrial dysfunction can lead to defect in the oxidation of the fatty acids, and these fatty acids can accumulate in the liver, which can damage the liver and result in elevated liver enzyme and low platelets. And because of damage to the liver, no gluconeogenesis will occur, so low glucose and high ammonia is also a feature of acute fatty liver of pregnancy. So acute fatty liver of pregnancy is basically a HELP syndrome without H and with hypoglycemia and hyperammonemia. Without H and with hypoglycemia and hyperammonemia. Acute fatty liver of pregnancy can lead to disseminated intravascular coagulation as well. How you can identify disseminated intravascular coagulation? And disseminated intravascular coagulation due to generalized dysfunction of vascular endothelium. Small clots are formed throughout the circulation. So all the clotting factors and platelets are consumed. So on laboratory investigation, because all the clotting factors are consumed, so the tendency to bleed will increase. So that's why there will be high PT, high PTT, and high bleeding time, and low platelets, and low fibrinogen. Low fibrinogen because the clotting factors are consumed, low platelets because they are consumed as well due to blood clot formation throughout the vascular system, and due to low clotting factors, PT, APTT, and bleeding time will be high. So high PT, high PTT, high bleeding time, low platelets, and low fibrinogen in a pregnant female will make the diagnosis of disseminated intravascular coagulation. So disseminated intravascular coagulation is a complication of pregnancy, as well as there are some other causes of disseminated intravascular coagulation. And the most important of them is sepsis and surgery and major trauma and cancer. They can also cause a disseminated intravascular coagulation. Sepsis, surgery, major trauma, cancer, and a complication of pregnancy. Remember that AFLP can also lead to disseminated intravascular coagulation, as well as placental abruption can lead to intrauterine death and then disseminated intravascular coagulation as well. So if in the question they ask you that a 29-year-old female had preeclampsia and was delivered by C-section, he is now complaining of right upper quadrant pain. What is the next best step in the management of this patient? So a woman with a history of preeclampsia present to you with right upper quadrant pain, the first thing that you will do is to check her liver function test. And liver function test will show elevated liver enzyme. Don't forget that preeclampsia is an important risk factor for HELLP syndrome. So this was all about acute fatty liver of pregnancy and HELLP syndrome. So who will repeat the features of acute fatty liver of pregnancy? What are the features of
elevated liver enzymes, low platelet, hypoglycemia, and hyperammonemia?
Yes. So in one line, AFLP is HELLP syndrome without H and with hypoglycemia and hyperammonemia. So our next topic is ectopic pregnancy. We'll end our today's lecture here. We'll continue from ectopic pregnancy tomorrow. So I'll see you guys tomorrow, and we'll try to finish the obstetric chapter in tomorrow's lecture. And after obstetric, we'll start respiratory medicine. So it's a goodbye from my side. Take care, Allah Hafiz, and good night.
Allah Hafiz.